Good morning, Richard and guests. My name is Demi and today I'll be presenting a proposal to modify paramedic practice. This modification will aim to respond to the needs of the homeless population. The reason for presenting this proposal was due to my recent community placement that highlighted a need to account for the socioeconomic factors that impact the health of the homeless. This placement emphasised the severe marginalisation of the homeless and raised issues in terms of their healthcare access, cost, and trust in healthcare services. From the perspective of a paramedic, I believe there are a number of actions that can be taken to improve the healthcare of the homeless. However, the initial change needs to look into the educational focus of paramedic degrees and how active we as paramedics really are within the community. Before I begin explaining my proposal, it is important to understand the homeless population and why the healthcare needs prove to be different. In Australia, there are 116,427 homeless individuals, with rates predicted to increase. These individuals are defined as homeless due to their accommodation being that of inadequate, with no tenure to extend, and a lack of space for social interactions. Given these circumstances, majority of the homeless population experience social exclusion, stigmatisation, discrimination, and indifferent services from many organisations. This places a major risk on the homeless as it creates difficulties in accessing basic provisions, hygiene, and healthcare. These health disparities are then also exacerbated by a complex burden of simultaneous medical, mental health, vulnerability to physical and sexual violence, and substance abuse problems. Essentially, as outlined by Bowen, Sabino, and Irish, the significant marginalisation, exploitation, and recurrent nature of health inequalities places the homeless at a cumulative disadvantage. And unfortunately, this disadvantage continues to be exposed in conventional healthcare systems due to problems in misinterpretations and approaches to their healthcare needs, subsequently deterring them from accessing and affording healthcare. One of these downfalls in current healthcare system is communication with this population. As outlined by research, to increase healthcare accessibility in the homeless, healthcare professionals have to focus on information, explanation, and communication. It is crucial for practitioners to understand that health language, systems, and information delivery can be difficult for the homeless. Homeless individuals rely on face-to-face contact to seek information and changes to health interventions and management plans. The issue that stands with this, however, is that contacting the homeless regarding health information, services, or appointment is ineffective as they do not have a means to be contacted. This population rely on healthcare that is brought to them, a service that is predominantly not available in many primary healthcare providers. There are also difficulties in mental health care for the homeless. This proves to be a significant issue as mental illness is both a cause and consequence of homelessness, and rates are significantly high in this population. This is primarily because the homeless suffer the consequences of living in such an unstable environment and are more exposed to traumas and challenges within society. However, due to high costs, low access, poor healthcare training, and unresponsiveness to traditional treatments, homeless mental health conditions continually go inconsistently treated or undiagnosed. Another problem to consider is a common mistrust between homeless individuals and healthcare services. As explained, the homeless population are diagnostically difficult. They suffer from high levels of substance abuse, trauma, existential despair, and an unstable social environment. Given these factors, they require unconventional healthcare approaches, such approaches that are not always provided by healthcare services. Due to this, homeless individuals have poor experiences with the healthcare continuum. Homeless individuals even reiterate feelings of stigmatisation and prejudice and a lack of dignity and equality in healthcare providers. These misinterpreted and mistrustful experiences is what breeds this mistrust by the homeless and tends to deter them away from accessing healthcare. Finally, is the problem of affording healthcare. One significant structural barrier for the homeless is financial difficulties and a lack of health insurance. Due to these financial difficulties, the homeless often have to contend with priorities, and usually securing food and shelter will take precedence over healthcare. This is further reiterated by the Australian Institute of Health and Welfare, who reports that 40% of homeless individuals state that the cost of services was the main barrier to accessing healthcare. More specifically, some frequently mentioned financial barriers include money for transport, health benefits, or prescriptions and allied health services. Now that we understand the health inequalities faced by the homeless, we need to look at a paramedic's ability to effectively tailor their care to address such issues. When we think of a paramedic, what do we think? I'm assuming the picture behind: fast-paced, lights and sirens, trauma incidences, managing blood, broken bones, heart attacks and strokes. Although this is a reality, it's only a small reality. As seen in the picture up front, currently paramedics are being called to more non-urgent calls exacerbated by social factors. As a result, there has been a shift in the need to first focus on the complexities of a patient's social influences. It is believed that focusing on the social influence of one's life helps better understand their current medical conditions and apply more appropriate care. The issue that arises, however, is that this form of care does not follow the traditional biomedical orientated training paramedics are taught. There has in fact been reports of a lack of adequate training and knowledge amongst paramedics to effectively address complex social factors that contribute to a patient's health. This is primarily due to poor integration of understanding the social determinants of health that influence many marginalised groups like the homeless. Whilst paramedics are aware of the social factors that influence health, it comes down to their approach and assessment in managing these complex social cases. Studies believe that paramedics need to be better equipped in tools that promote effective social and environmental assessments. For example, questionnaires that outline a patient's risk for housing, financial, and daily provision access. The problem with this, however, is it would have to see a major shift in paramedic education, culture, and governance. Another issue with paramedic care for the homeless is a reliance on emergency departments as the end result of their care. As reported by Davies and Wood, the homeless suffer from many health barriers that make it far less likely for them to access primary health care. To account for this problem, homeless individuals overuse ambulance services as a means to access health care for non-urgent cases. Non-urgent cases that would be better addressed in primary care settings or preventative health services. However, the paramedic care continuum only leaves paramedics with two options: transport to the ED or leave the patient at scene, and given the unstable environment in which majority of the homeless live, leaving at scene is not viable. This sees continuous cycles of homeless individuals in and out of hospital with no real definitive management plans or means to maintain communication, proving there is a gap in the paramedic care continuum that needs to focus on collaborating and working with community-based organisations to bring more appropriate care to this population. To divulge this information in short, we can see four main issues with homeless healthcare: poor communication, poor mental health care, poor trust, and poor financial accessibility. Coupled with this, we have identified gaps in paramedics' ability to address such issues: poor education, and a lack of community networks and outreach efforts. This brings me to my proposal to modify paramedic practice to help address these health inequalities and gaps in the paramedic care continuum. The first proposal is to reshape paramedic education at the degree level. This proposal aims to emphasise the importance of social factors on health. As outlined by the Australian Institute of Health and Welfare, this proves to be important given that the social determinants of health have a significant influence on morbidity, mortality, and health status. By no means am I thinking to steer away from trauma and medical management, however, add an additional focus on the social aspects of health. Although universities do teach students about the social determinants, there is an opportunity to implement a more emphasised and practical focus on how to provide care for those impacted by such factors. Through this new focus, paramedics can be taught how to effectively assess a patient's social and environmental influences, as well as learn about those unconventional treatments and organisations better suited to the homeless population. An effective method to do so would be to introduce this focus into existing subjects such as HLSC 111, or even develop a new subject and syllabus that teaches new paramedics how to assess complex social factors in the homeless population. On top of this theory, the practical learning could follow the guidelines of a new QAS CPG that outlines, for example, a questionnaire to assess a patient's risk of housing, financial, and daily provisions access. The practical experience could then be tied in with a community placement where students work for organisations that run outreach programs for the homeless. With this shift, new paramedics will be better equipped in understanding the needs of the homeless, subsequently allowing for the development of therapeutic relationships and mitigating those mistrustful perceptions of healthcare systems. A paramedic organisation that is trusted by the homeless and understands those unconventional approaches to their healthcare could also help to reduce the misuse of emergency departments and promote primary healthcare accessibility in the homeless. However, this raises another problem. How do we as paramedics implement care away from the emergency department? It's all well and good to teach new paramedics how to practically manage the homeless, but without proper networks in the community, the homeless would still end up at the emergency department. This brings me to my second proposal, that is to increase the active engagement of paramedics with the homeless and develop networks between paramedics and community-based organisations. As outlined by Alano and Pinto, there is a recognised need to bring care services to the homeless in a location where they can be found. This is primarily due to those social determinants of health that create health inequalities related to their inability to access and afford health care. Davies and Wood also reiterates that homeless individuals overuse emergency services for problems better suited for primary health and preventative services. Understanding this provides paramedics with an opportunity to bring on a new role, a community paramedic in major cities. Their primary job would be to bring care to the homeless and collaborate with community-based organisations. To implement such a plan, I propose developing a community care shift for paramedics where they steer their focus away from medical and trauma management to addressing those health concerns exacerbated by social factors. The proposed plan would aim to have paramedics work with community-based organisations that already provide primary health care and complex coordination services for the homeless. Take Sunny Street for an example, which is a community-based organisation that provides general health assessments, chronic disease management and support, wound care, referral to services, mental health plans, immunisations, health education and promotion, and social prescriptions, a number of tasks which fall within paramedic scope of practice. Through working with an already developed organisation, it would also help maintain records of those complex coordination efforts between primary healthcare services and avoid any losses in communication and continuity of care. This would allow for new community paramedics to arrive at an organisation like Sunny Street, provide care and transport as directed by an organisation already immersed in the homeless population. By working with such an organisation, it will give these community paramedics options of care outside the emergency department, as these community-based organisations generally have long-standing networks with primary health and preventative services. For example, detox centres and mental health hospitals. There could also be a plan of action to have a contact number to the community paramedics on shifts so that other crews who are emergency focused can hand over community-related cases to these community crews. Essentially, these shifts would aim to share the responsibility of care continuity for the homeless rather than dropping them at emergency departments where they do not receive appropriate levels of health coordination. Some logistics that will need to be considered for this role include rostering and staffing. There will need to be a consolidation with workforce planning and the OICs to determine the staffing available who have learnt the appropriate skills at university. There could also be the idea to use the casual pool of staff, which are usually made up of new graduates who are wanting more hours. Shift timings. The plan would be to run shift times in accordance with the hours of the organisation. For example, Sunny Street are usually 9 to 5, Monday to Friday. Developing networks with community-based organisations. This would have to be achieved through the headquarters at QAS with a set plan for the intentional use of paramedics in their community organisations. Networks would have to be with organisations that already do outreach programs to communities with increased homelessness. For example, Sunny Street or Anglicare Homelessness Services. Equipment supply, a community paramedic could use any spare kits at station and work out of a pod car, which are generally fully stocked. Furthermore, by introducing paramedics into the community through this plan, it could potentially help mitigate a number of health inequalities faced by the homeless, this being poor communication. Through this proposal, we as paramedics can help the homeless understand the health systems better, improve their health literacy, and provide face-to-face care, which, as explained by Stanton et al., is what the homeless rely on to seek health information. Next, mental health care could improve as paramedics could be more orientated to the social services and agencies that operate in their area. This could help reduce those unwilling mental health EEA transports that have known to further exacerbate psychological distress and create negative perceptions of emergency care. Finally, bringing care and increased access to extended services can help the homeless better afford and access more unconventional approaches and help build trusting relationships that encourage future healthcare utilisation. To conclude, my proposal aims to educate the new workforce of paramedics to better understand the needs of the homeless, to which they can utilise this knowledge in their new potential role as a community paramedic. The benefits of this shift aim to address the cumulative disadvantage of the homeless due to the health inequalities they experience in being able to access, afford, and trust health services. Being a healthcare provider, we have a responsibility to engage with marginalised communities to help promote trust, utilisation of resources, and sustainable partnerships to achieve better health outcomes for all. Through this proposal, it will hopefully see more educated paramedics showing face in a community that desperately needs our help and encourage trusting therapeutic relationships that help the homeless develop their voice for healthcare. Thank you. That concludes my presentation. The next 8 slides are my reference lists for the information provided and then for the pictures used. Thank you.